Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps.
We're going to pick your case, of course. So
Of
let me
course.
see how people did. So yeah, so I guess walk me through this case, at least your
Yeah,
presentation.
so this is young, mid to early 30s, who fell off of a ladder. And, by the time he kind of got to us, he had been seen at I think one or two other hospitals, got transferred in, type of situation. And obviously he's got if you look at the x-ray, he's got deformity about the foot. He's otherwise in good health. He doesn't smoke. He works on his feet as a mechanic, and no other medications that you'd be concerned about. He's pretty, like, he likes hunting and being on his feet quite a bit. So, these are his initial presenting x-rays. This is what I got called by the resident, for his post-production x-rays, and CT scan. So obviously there was an attempt at reduction. And it may be worth mentioning, this is what I see when I look at the x-ray is basically appears to be a primarily ligamentous homolateral Lisfranc dislocation. Maybe a small, flex sign off the base of the second there near the medial cuneiform, but otherwise looks mostly ligamentous, when you look at it. I think the CT scan confirmed that, if I'm not mistaken. Yeah, and you can see the first metatarsal should be. Can you draw where the first base of the first should be on this? Yeah, so it should be like all the way over there. So it's like hopped one joint over completely to the lateral side. So these are, we talked about. We were just doing, foot and ankle emergencies this morning in our own lecture, and we were talking through like strategies to try to facilitate reduction in some of these dislocations like this. I mean, this is a hard dislocation to get reduced in the ER, and it depends like how quickly they present. It depends how swollen they are. Depends on the anesthetic that you can get. If they're not very relaxed, there's probably not a great chance that you're going to get it. And they never look quite perfect when you're done. But do you have any strategies for how you teach your residents how to manage these?
Yeah, so I agree with you. Very hard to get perfect. They could be high energy injuries, very difficult to reduce. What I did as a resident and now kind of advocate for some of the residents to try here is almost how we reduce distal radius fractures, almost like finger traps.
Yeah.
But hang the foot, hang the toes, and try to move it over. I think that gets you the best, slow traction over time.
Yeah.
Has been more successful, I think, and it just makes them a little bit more comfortable because you can kind of see it almost pop back into place. But they're extremely unstable injuries that you could usually, you've torn all the structures, right? They're, like you said, ligamentous injury, like you tore, so you get it kind of looking okay, and then all of a sudden you can kind of chuck the foot back and forth fairly easily.
That I think that's a great point, because it is going to be, um it's going to be hard to hold it there stable, and sometimes even where to the point where they need a provisional fixation or provisional pinning of that midfoot. So I think that's an excellent point. So one of the things with this is obviously it's dislocated. Make decision making on how quickly do you think this case needs to go to the OR? Is it that night? Is it the next day? Do you splint them and send them out? Like, how would you manage that?
Right. So, yeah, so I don't think this needs to go in the middle of the night unless the skin is at risk there. I mean, it's at risk, but like if as long as it's blanching and so forth, because I think hopefully you can make it look better with a closed reduction, at least a little bit better. You don't have to get it perfect, but just to take some stress off that medial cuneiform here.
Yeah.
Um, I think that would be nice, just so you don't create any more further soft tissue injury. But I would take this the next day usually, and if the skin is okay the next day, I would plan to do surgery acutely. Otherwise, I would reduce it in the OR and bury some K wires, or some screws just to kind of temporary hold this until the swelling improved.
Yeah, I think that's a great plan. I think that's reasonable. This gentleman is a young guy, and he's not otherwise unhealthy. Getting a history is so important too, because I've seen this X-ray show up in a diabetic patient with Charcot arthropathy look exactly the same, almost but without any trauma, right? Or it was a very subtle injury, and it's been going on for weeks. And so being able to discern, hey, this actually is an acute injury with sudden displacement versus
Hmm.
whether a gradual displacement or a Charcot presentation, I think is important as well, because you can get the call from the ER, oh, this patient's got dislocation. I don't want you necessarily taking that patient down and trying to reduce it because one, it's not going to be fruitful, and two, it's just a waste of your time. So you get a good history, know what their background, do they have Charcot arthropathy, that kind of thing.
Absolutely. And the other thing is not only looking at the AP film here, where you can see that the, um, you know, basically all the metatarsals are dislocated laterally, but looking at a lateral film here is you want to look to see the dorsal displacement,
Mhm.
because that can also be sometimes impinging on the skin here and causing a problem. So I always keep that in mind, because the lateral here doesn't look that bad, but you can see how that first TMT is dorsally displaced and putting some pressure on the soft tissue structures as well.
Yep, completely agree. Okay, so dislocated, we said, hey, we're probably going to be taking this patient to the OR within the next probably 24 hours of the injury, for fixation or reduction in provisional pinning. I don't know if that CT scan will play or not. Looks like it will. You can see, some small flex, small avulsions, but mostly ligamentous in nature.
And you can see how it's completely dislocated. You basically have the first base of the first here, articulating with the middle cuneiform.
Yeah.
So, which is what you see on the X-ray too. I don't think there's any surprises with these with the scan.
Nope.
Let me just see the sagittal here.
Do you always get a CT scan, or do you think it's
I
it's unnecessary?
I always get a CT scan because I sometimes you
Yeah.
you you might notice some other fractures that are non-displaced. But I mean, this one needs surgery. It's not going to help you determine surgery. It may affect your plan, fusion versus fixation.
Yeah, and I just had a case where, on the CT scan, it didn't change what I did in terms of the midfoot, but it did affect, like, there was a navicular fracture that was non-displaced. I was kind of looking at the calc as well, and that had a fracture across the anterior body. Different mechanism, but you get the point that some of these traumas, there's other injuries that are hard to discern on the X-ray.
And if you look at that, so like going to the question, would you get a CT scan? So 75% of surgeons voting on this case would get a CT scan, and that's from
Yeah,
like 84 different countries. So I think that the majority of people would,
yeah,
and not really a big surprise there, right? I mean,
no.
um, some of the other tests, I mean, like 2%, 4%, but yeah, most of the time people are getting a CT scan.
All right, so, and was there a question there that we wanted to talk about? Okay, so closed reduction in the emergency room. That was a little bit um, controversial there. Kind of even split between no, I'd not attempt
I,
versus those that said yes, they would attempt.
and I wonder if we could have asked this question a little bit better is, if we had like a clinical photo of the soft tissues,
Yeah.
right? The soft
Mhm.
tissues looked okay, and it's, hey, you're going to take this first case in the morning. It's like, well, why should you attempt closed reduction, right?
Yeah.
Might be some argument against it, but
Well, especially if you're pushing you're getting the thumb right on that spot because you're trying to pull it up and you're trying to push on that. I mean, that even though you're not opening it, that causes trauma to the skin that's already been traumatized. Now you're putting a lot of pressure on there with your thumb. You have to be careful about that, with
yeah,
these attempts at close reduction.
absolutely. And I think that's probably a resource issue. I mean, the big thing here is do not send this patient home. I think that's the get them taken care of. All right. So here, if you choose operative fixation or operative management, what type of treatment would you choose? So
I love
reduction,
this question. This is awesome.
reduction fixation versus primary fusion. And I was a little shocked by this, to
I
tell
was
you.
too. Yeah.
And so which one would you, I mean, obviously this is your case. Are you a fixer or are you a fuser?
I'll use both, but in this case, I did a fusion, and I'll tell you why. My rationale is because I've tried fixing these. Like, I think you can get it dialed in, you can get it back in a good reduction, especially if you're taking care of it early on. You should be able to dial that in, look exactly where the cartilage goes, bridge plated everything. But they shift. over time. When you follow them out, at least that's been my experience. When you think about, we're always trying to like decipher what the literature says in terms of, in this case, you're talking about fusion versus fixation in a midfoot injury. And I think a lot about that the paper that came out by Coetzee and crew, to me, this is like the spirit of that paper. This is the type of injury that this primarily ligamentous homolateral dislocation, that to me is what that paper represents. And so that in this case, I am choosing a fusion. Now, right or wrong, I don't know what are the ramifications, but I think that's a good option because I know I can get it right. I can see the cartilage, I can get it dialed in and get the foot structure back. And they don't need another surgery as long as they
So I got
heal.
a question. Do you think if we were to compare the US and the UK, who do you think would fix or fuse more?
Oh, that's a good question. I guess I'm tempted to say is the UK would be more likely to fix it. That's what I think is they're going to say. You
All
have to do
right. So
UK or can do all of Europe.
yeah, it's we can't do all of Europe right now. We would have to pick all the countries.
All right.
So
Well, I can't remember that my geography is bad. So,
yeah, I know. All right, let's see this. See how this is
all right.
working.
Our brothers across the pond. What are we looking at? What was it? It was
So, well, this would just be the UK. Hold on. We got to do them separately.
Yeah,
Hold on.
see what yeah, you got United Kingdom, United States.
I'll
Oh,
do
I see.
United
Okay,
States
yeah,
first.
just do United Kingdom.
So, United States, 27% are going to choose to primary fuse.
Okay.
Now, so 27%. So now if we do the UK, look at that, 5%.
92%.
Yeah.
Yep. Is that
And
what you expected?
I actually thought they would fuse more than us.
Oh,
Do one surgery, but I mean, I guess it all, I mean, we could go back in the data more to actually see who answered these questions, whether they're foot and ankle surgeons versus trauma surgeons. But I wasn't expecting this much of a drop off. I thought it was going to be like 50-50 still, but I so it's a little bit interesting for me there.
it's fun to see what, how they manage things in different parts of the world. That's for sure.
Yeah. But I'm with you. I go back and forth whether to fuse or fix. I think sometimes when the I don't know, like it's hard for me to fuse a really young person, and so I go back and forth still. I know that some of the data suggests it's fine, but for me, I don't know, fusing like a 21-year-old who was in a high-speed MBA, if there's any comminution, I find it more difficult to align the foot. If there's comminution of the
Well,
metatarsal associated with it, not a purely ligamentous injury like
exactly.
so.
Yep. And I think I should have, said that as well, that if you have a case that's actually highly comminuted, in a lot of those cases, I'm not fusing it, even though that maybe seems a little counterintuitive, but it is hard to get in there and adequately prep that joint and compress and have fixation across it when you have that much comminution. So in that situation, I'd do the same thing you would do. I'd most likely fix it. But in this case, primarily ligamentous, I could get it well lined. I could get it compressed really well without really losing much length. Because that's the downside. Like if you have a first TMT that's really it has a lot of interarticular fractures and stuff, then I think fusing is going to be challenging. And so in that case, a lot of times I'm just bridge plating theirs.
No, absolutely. That I agree with. So, how would you temporize this patient? I mean, I don't know that I agree with this. No, I would not temporize. I would just fix it acutely. I think as long as unless the soft, was all blisters and so forth, this is something I would just get done the next day.
Yeah, I think that's just depends on your comfort level too with managing these or, interest in managing some of these injuries. I do think it's reasonable to think about reducing it and pinning it. And in that case, I think the question would be interesting of where are you going to put your pins? Because, if you're asked to manage this in a way that whatever approach you decide to use, like where you put your pins can matter in terms of where you put your incisions. And so that's something I kind of wrestle with a little bit. And I kind of have my standard approaches. So I think I know where I'd want to go. And so ideally put your pins outside that plane. But I
Do you
definitely
bury your
see
pins? Do you bury
what.
them?
Usually not, but again, like I'm not using pins that often because I'm going to be just fixing it. Now, one thing that I have seen done, I've had some of our trauma partners do, is they'll actually do plantar based pins, and then they'll just run them up the canal, and that's kind of nice because then they're totally out of the approach. You know, like you do retrograde pinning of a metatarsal. I've had a couple cases if that's the case, and this would have lended itself actually quite well to that. You just run it up the medial column in the intramedullary canal, and then you're totally out. Your skin incision for the pins is on the plantar side of the foot, and you're working from the top. So that's kind of that's an option that you can use as well. And then an X fix, you can use a little mini X fix on these. It's a good option as well, especially if you're comfortable using an X fix.
No, agree. So this question, if you chose primary arthrodesis, which joints would you fuse? So this was all over the place. I mean,
Yeah.
a little bit, I guess. How about you? What joints would you fuse here?
Well, I did all three of them, first, second, and third. I felt like that gave me excellent stability. I was also a little bit I felt like I needed to include all three, and whether this is correct or not, feel free to push back. But I felt like I needed to include all three because you look at the fourth and fifth; they're dislocated as well, and I think my stability to those joints is contingent on having good fixation and alignment on the first, second, and third joints. And so I think I think our brothers and sisters in UK have shown that maybe pins are not necessarily necessary in the fourth and fifth. Like we tend to use those. But I think that's like kind of a next level question on this is, okay, so you fixed first, second, and third. What do you do with the fourth and fifth?
Right. And I'm with you on that. I would do first, second, third. And I tend to leave the fourth and fifth unless they're obviously if they're dislocated, I open reduce them. And if I need to open reduce it, I'll put a screw across it. That's temporary, like
Yeah.
almost like planned hardware removal for like the fourth or the fifth.
Yep.
If I need to just almost pin them, I don't want to pin it always because I think pins can move and uh, I don't think it's as rigid. So I just plan a hardware removal to take out whether I reduce it with a cannulated or a solid screw and just, take that screw out in a couple of months.
I think that's a good idea. Like, just having something to give you a little bit more stability there. But I do kind of rely on, I think I don't know if it's a paper yet, but Lyndon Mason has talked about that. They did a project looking at fourth and fifth TMT joints and whether or not they were necessary to be pinned. And I don't think we need to be, as aggressive with fixation there. But we want that joint to move quite a bit on the lateral side. So if you fix it with anything, it's going to get stiff.
Yeah, and I think part of it is, and I've not seen that paper, but I know I've seen his like preliminary results, and I think he had an abstract.
Yeah, I think that's it.
I think that assumes that the fourth and fifth are reduced.
Correct.
So like, yeah, I mean, if because if your fixation and the medial and middle column is holding the lateral column reduced, it's like, well, it should heal there, right? Assuming that they're not walking on it right away. So I think his data makes sense.
Right. And I think that's a good point. In an acute situation like this, they're probably going to follow everything because you're getting to it pretty early on. If it's more chronic and it's scarred in a little bit, I could definitely see a situation where you have to do a separate incision or a separate approach to the fourth and fifth and actually clean it out to get that to reduce. You may have to do that to get the whole foot reduced, to be quite honest, because
Yeah.
that stuff gets kind of sticky over there. And then that would make sense that you maybe have to pin it in that case.
So here, if you chose when you fuse, what are you using usually as your fixation construct
I've
most of the
used uh, I've used plates, I've used staples, I've used crossing, cannulated screws, solid screws. I think you go with what you're comfortable with, what allows you to get rigid fixation, get the alignment right, and then what's available. But I think in these kinds of cases, I kind of ask for everything. To be honest, I'll have plates, I'll have staples, I'll have screws, and then it kind of depends on how it lines up, what the anatomy looks like based off what I use for these. How about you? I mean, are
I'm
you?
the same way for that. I'll use whatever fits in whatever I need at that point, and I like to have the whole kitchen sink available
Yeah.
in the whole box.
I think having something like a 2.4, 2.7 screw plate and screw construct is good. I think having 3.5 or 4.0 cannulated screws is a good option, and then having some staple constructs is a nice option as well. And I think you can manage most things that are going to be thrown your way if you have that kind of setup.
What about you
So
here? Go ahead. Sorry.
I didn't use any bone graft or biologics in this case, and part of the rationale is acute injury, a lot of biology already happening, kind of ramped up for a healing response anyway. So I didn't use any bone graft. I think you could make a case if there's a big defect that you're trying to fill in, from comminution or whatever. But most of the time, particularly in this case, you could see there wasn't a lot. There wasn't, you know, the bones were pretty good still, so I could fix very stably, compress. I didn't feel like I needed any bone graft. I don't know if you're how you approach these.
Yeah, so in the acute setting, I don't as often use bone graft, or sometimes I'll take some heel bone graft. Um, something if I need it, but not so much like you said in the acute. If it's delayed or chronic, I'm taking bone graft almost 100% of the time for those patients.
Yeah, yeah. For the more chronic things, because a lot of times you get the joints don't line up right. You have a little bit of a gap and defect, and it's more of a chronic situation. Um,
Yeah, so this was a little bit all over the place too, where they're
yeah.
getting the graft from.
You don't need a
Um,
lot for this, so I think going to the calc is a great option for something like this. And it's super. I mean, it takes a couple minutes, and you can get enough graft that you can fill those defects.
right, and here's this use of, I don't use a lot of biologics in the foot. Maybe that's why I have some non-unions. I don't know. Um, but it's also like keeping it there. Like, have you ever, I mean, do you ever use BMP or anything like that for midfoot fusions?
I have used it intermittently, but most of the time when I'm doing midfoot, like I definitely use BMP, but most of the time when I'm doing like a midfoot, I'm going to take cancellous autograft, or use like something off the shelf, not necessarily BMP.
Yeah, I just wonder where you put the BMP, because
Yeah,
like putting a spot, your incisions are small, like it
yeah.
does. uh, let's see here. If you chose reduction fixation, what technique would you use? And you're like, I think the most of the people chose RIF, which I think that makes sense. I mean, if you're gonna, this is not something you can really percutaneously pin. So
I
I
don't
could
think
see.
so. Although, I mean, maybe if you are pretty savvy with if you have an X fix that you can kind of distract it, you get to it early, maybe get your reduction, and then you can kind of reduce it a little bit, or kind of now they talk about some of these minimally invasive approaches, and it kind of depends on how you fix it, and then do percutaneous screws. I could see that maybe working out for you if you're savvy with that.
Yeah, so I've done a couple just percutaneously when they've been this bad, when they've had horrible soft tissues,
Hmm.
where I've done it percutaneously and gotten it close. And then I was like, I'm going to come back and fix it. And then like the soft tissues didn't allow me to, or the patient didn't allow me to. And I think it's N of two in the last few years, because I can think of one right now who recently came into my clinic for a different issue, and they did okay.
Yeah.
Um, so because these injuries don't do great anyways, so maybe less was more, and it worked out, but it's not something I would recommend. Um, yeah, the same type of answers here. If you're going to choose RAF alone, what fixation type would you use? Plates and screws. I think
Kind
that's
of
a
wish
good
they
one.
would have put staple in there. I didn't think about that when we were putting this question together. Maybe they did, and I just don't see it. But
There's a staple, yeah.
is there staple option? Did anybody select that? Because that's the one question I have. Nobody said that. Is I've heard some people talk about using staples for ORIF of the midfoot, and the whole idea of that is to provide this idea of continuous compression, and maybe it's stability that it provides, but it seems a little counterintuitive when you're talking about bridge plating or bridge fixation across the joint surface.
Yeah, I'm sure they're going to break, right? I mean, that's just like a plate would break.
Yeah,
So,
maybe that's
but
okay.
once the ligament heals, or the dorsally or planarly, it should be okay. I would assume, just like if a plate breaks. What's your weight bearing status for
I
like
keep
a
them. I'm a non-weight bearer person for these. I don't. I mean, maybe you could let them heal
when
weight
you
bear a little
non-weight
bit.
bearing?
How long?
Yeah.
I 8 weeks. I usually see them at 6. I repeat X-rays, and then I tell them, okay, in 2 weeks you can start weight bearing, and gradually increasing activities, and then progress from there.
Yeah.
All
So
right,
yeah,
this is not our like the intraoperative images from this aren't amazing. So I wish I could have had a little bit better images from this, but you can kind of see what we were attempting to do here. You see the joint's been prepped, kind of, and
yeah. So you started. Can you tell me your sequence here about
yeah.
reduction?
So for my incisions, I make an incision kind of over the just medial side of the first TMT. So kind of almost kind of you see that plate sitting off to the medial side, kind of in that general vicinity. And then my dorsal incision is over the top of the second and third TMT, so that I can get to both of those. And then I feel like that gives me enough bandwidth. If I need to get to the fourth and fifth, I can. It gets me enough of a bridge between the first and second that I feel like I can close it without too much difficulty. And then I usually start with the medial side and then kind of work my way laterally. So then in this case, I prep the joints, and then and probably made sure I could reduce it first and then prep the joints, use a like a lamina spread or something to be able to expose those joints, and then reduce it. And I have this like straight modified clamp that works nice for some of these midfoot injuries, or even just like a straight point to point reduction clamp to try to compress that joint a little bit and to pull it into a little bit more um, abduction, if you will, because I think that's the key. I've had a couple of these where I haven't paid close enough attention to the first TMT joint reduction, especially if you're doing a fusion, because then you lose your cartilage. So you have to think, that first supposed to be angulated a little bit towards a little bit medial, a little bit away from the second. And so you have to make sure you recreate that. So sometimes even to the point where I'll look at the cartilage on the medial cuneiform before I remove it and make sure I see where it goes. And then I can make sure I get that reduction right, because that's what creates the space to pull the second and third over, and then subsequently the fourth and fifth. But I've definitely done it where I've left it too straight, meaning it's too much adduction of the first, and then they hate that, especially if you have somebody who already has a flat foot deformity to begin with. Then that just accentuates the whole thing, and they look awful. And you're like, where did I go wrong? Because it's a very subtle thing, but you have to make sure you restore that abduction. I think I'm saying that right. So that's my soapbox. That's where I've messed up before. It's pulling the first far enough over.
Yeah. So you're keeping it. You mean, like, for example, you want to keep
Yes,
like
correct.
this angle.
Yep. And that's where sometimes, when if you see them in clinic, sometimes you can get a comparison view of the other side. So some of these may be more uh, uh, cold trauma that comes in. You can get an X-ray of both feet, and you kind of have an idea of where you need to put it, what their normal is. Um,
Yeah.
And then, so then I've spent quite a bit of time on the first and make sure I got that right. I would say this from a couple of years ago. One thing I have started doing more and more is if I'll get the first bridge plated, sometimes I'll use 90/90 plating, and then I'll get the third oftentimes plated because I usually have direct visualization at that level. And then it can be a little bit with where I put my incisions, a little bit difficult to get to the second cleanly, and it's feel like you're stripping a lot. So in some of those cases, once I got like the first and third, then I'll just put screws, compression screws, maybe across the Lisfranc joint and across the second TMT joint. And that works pretty nicely because you're working kind of in that trajectory anyway with where the incision is. And then I don't have to worry about like exposing the second metatarsal. You got the neurovascular bundle right on the top of that area usually. And it's just a little less hardware to manage as well.
Yeah, what I've done too, I've gone several times now. I put it like a retrograde Lisfranc screw here.
Yes. Well, that's what I do on all my. So you're going from lateral to medial, right?
Yeah, from
Yeah,
lateral to medial retro. It's just easier for me because like you
correct.
said, you have it all exposed. I have a plate immediately, like you put here, and then so I just like there's nothing there, and I can just put a screw in, and then I can still put a dorsal plate across the second
Yep.
TMT.
That would,
Doesn't.
and you could argue I should have done that in this case. When I do a fusion, I'm probably less aggressive with fixing across the Lisfranc joint because, and maybe there's a opportunity for intercuneiform instability here, but I kind of feel like if the first and second and third are fused and stable, it's probably going to be okay across the intercuneiform joints. The other thing I will do, and I didn't do it here, is that on that medial plate on the first, that usually is medial enough that I can run screws across the intercuneiform
Yes.
space as well, and I'd run it all through that plate. And then I can feel like I can kind of stabilize that entire construct.
Yeah, I do it very similar like you. Like my incision, I cheat it very medial, uh,
Hmm.
like you do here. And you know, I think this looks great. I mean, if you're looking at these, the bilateral standing AP view, I think you've really nicely restored the anatomy here for, especially if you look at the pre-op image. I wish we could put it side by side right
Yeah.
now, but 100% improved.
Yeah, I couldn't be happier with the way this looks, and he did well. I mean, at this point, he was back to his manual job and on his feet. And I mean, these take, like you mentioned, these take a long time. So I feel like this is a huge win for this guy that he can get
Yeah,
back to his work. And it's like you got to tell him, like, listen, it's a hard go. That first day back, first week, it's going to be rough. And but give it enough time and just stay with it. Something like this, I think he's going to be able to get back to pretty much everything he wants to do, and I don't have to worry about hardware, arthritis, etc. down the road.
yeah. No, wonderful job here.
Thanks.